So we are discussing laparoscopic and robotic surgery, and this is the third section in which we'll talk about preoperative and intraoperative principles. So this section has been divided into three sections. In the first section, we'll talk about the preoperative evaluation. We'll see what evaluation is necessary for minimal access and robotic surgeries. Then we'll talk about the general intraoperative principles, and then we'll see how do we create a pneumoperitoneum. So let's get into it. So first of all, we have the preoperative evaluation. You need to prepare the patient for whatever you are doing. So you need to explain to the patient the procedure, the entirety of the procedure. You need to explain what will happen, how you're going to do it, and you need to have an informed consent so that the patient knows the advantages and the disadvantages of the procedure, and the patient has consented to the procedure itself. Before getting into it, you need to have a detailed history. You should ask for any previous surgeries. You should ask for radiation or chemo, any chronic diseases, any diseases for which the patient, the doctor needs to adjust for, any allergies. So the complete detailed history should be there. Then you should examine the patient completely. Examination is helpful in determining the state of the patient's body and the state of the patient's mind, and that is important in the maintenance and the post-operative management of the patient. Then you should always manage the pre-medication of the patient. If the patient has a chronic disease, you should know what that disease is and what medication is the patient taking, and how will you manage that medication during your surgery. Then prophylaxis against thromboembolism should be done. Usually the patient, for gastrointestinal surgical procedures, the patient is kept in a reverse Trendelenburg position. This reverse Trendelenburg position is high risk for thromboembolism and deep vein thrombosis, so one should always be careful for that. The prophylaxis for thromboembolism should always be given to these patients, and the prophylactic care, the pressure stocking, should always be there. Then the urinary catheters and the nasogastric tubes. Now these are controversial. In a traditional surgery, you would always catheterize the patient and the nasogastric tube would be inserted. Now, catheterization of the patient in a laparoscopic or a minimal access surgical procedure is only done to check for the urine output, and usually after the surgery or within 1 hour after the surgery, this catheter must be removed. Similarly, if the stomach is impinging on the view, or if the stomach is putting pressure on your view or the liver in a hepatic surgery, so you might pass a nasogastric tube to decompress the stomach. Once the decompression is done, or once the surgery has been done, you must remove the nasogastric tube before the patient regains consciousness. Now, obviously, for whatever you are about to do, you need to have informed consent that is required by the law. You need to explain the advantages and the disadvantages of the procedure to your patient, and after that, the patient should give you his informed consent. Now, what are the general intraoperative principles? So, general intraoperative principles, these include creating a pneumoperitoneum. So now creating a pneumoperitoneum has two methods. These are the open method and the closed method. So we'll see what these open and closed methods are. So in a closed method, here you can see, in the closed method, here you directly you directly enter a trocar or a varus needle into the abdomen. So you just take a fold of the skin, you pull it up, and you insert a trocar or a varus needle into the fat. The principle is that you will enter the subcutaneous, you'll breach the skin, the subcutaneous tissue, the fascia, and come to lie into the peritoneal cavity. So it involves blind puncture using a varus needle. Here you can see in the figure, these are the varus needles. Now it is fast and relatively safe, not completely but relatively safe. Potential for intestinal injury or vascular injury or introduction of the needle or the first trocar can occur. Now, in order to prevent or make it safe, you try to milk the fold of skin you have in your hand. So you pull up a fold of skin first from the abdomen and you try to milk it, so that if there's any structure within that fold, it might go back within the peritoneal cavity. However, still this is not relatively safe, and you might cause a vascular injury or perforate an intestine during this insertion of the varus needle. Now, how do we proceed in an open method? So in open method, a small incision of about 1.5 to 3 centimeter is made. Now the peritoneum is directly incised. First you make a small incision in the skin, after the skin, the subcutaneous tissue, the fascia. After that, you look for the peritoneum. When you find the peritoneum, it is directly incised. After the incision of this peritoneum, the trocar is placed, and now the abdomen is insufflated. So this is what happens in open method. Now the catheter is sutured in place. So in open method, there's direct visualization of the peritoneum, and with the direct visualization of peritoneum, you slowly open the peritoneum, as a result of which the abdominal organs, they settle down, and you can clearly visualize what is lying there below the peritoneum, and you can prevent any injury from occurring at that site. Now there's a third method as well. An open technique is followed with a smaller than usual midline incision. So you perform the open technique and you perform a smaller than usual midline incision. Now the access to the peritoneum is visualized. Varus needle is inserted under direct vision. Insufflation is carried out, and this allows the introduction of a laparoscopic port with a view to reducing trauma of the pneumoperitoneum. So you insert your probe in a certain direction, and this prevents any trauma that might occur due to pneumoperitoneum. So this is the third method. So this was all about this section. In this section, we talked about the basic principles of how to gain access in laparoscopic or minimal access surgery, the most important of which was the insufflation or insertion of the trocar. So insertion of the trocar has two methods, the open and the closed method. The closed method was just direct insertion, which was blind insertion, which might cause some damage. In open method, we perform a small incision, we visualize the peritoneum and then insert the trocar. Both are important. With time, with experience, you get to know how to use both the methods and which method is better suited for various surgical procedures. I hope you liked and understood this section. For further sections, keep watching sqadia.com.